Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we talked to Dr. Alessandro Fichera. Dr. Fichera is the Division Chief of Colorectal Surgery at Baylor University Medical Center in Dallas, Texas, and the Surgery Safety and Quality Officer. We talked to him about all the different types of surgery for inflammatory bowel disease, including robotically assisted surgeries. We talked to him a lot about J-pouches and J-pouch surgery. We talked to him about his conversations with his patients about sexuality and pelvic floor physical therapy, and we talked to him about the blues. Cheers.
Hi, everybody. Welcome to Bowel Moments. This is Robin.
Hey, guys. This is Alicia, and we are absolutely delighted to be joined by Dr. Alessandro Fichera. Dr. Fichera, welcome to the show.
Welcome.
Thank you for having me.
We are going to start out, though, with a very unprofessional question of asking you, what are you drinking?
Well, right now, I'm not drinking anything. Dinner is not ready yet, so I am drinking water and iced tea for now.
Now, I do have to ask you, this is normally not the second question, but you are quite the cook. So what are you making for dinner?
So we are on a diet, so I'm not going to go wild tonight. Just some probably a small burger with some potatoes, nothing major, nothing too sophisticated. We do go back into the old habit at least a couple of times a week, but not tonight.
Because I have seen that you have absolutely beautiful posts every once in a while of food that you make that looks delicious and gorgeous. And so, I'm a fan.
Yeah, no, it's what I do to relax. Yep.
I love
it comes easy for me, and it's something I do when I come home, often with an adult beverage when I cook.
Sounds good. Robin, what are you drinking?
I have two options available to me tonight. I have a little club soda with lime as a backup, but I was channeling you today, Alicia, and I have a Kir Royale, which is champagne and raspberry liqueur.
Oh, that sounds very nice.
Yeah.
I got real excited today because I was like, what am I ever going to do with these bottles of vermouth that I bought for specific cocktails? And so I just searched vermouth lemon cocktail, and it came up with what's called a Man o' War. It is bourbon, orange liqueur, sweet vermouth, and lemon. That's it, lemon juice. So it's very pretty though.
Sounds delicious.
It does sound delicious.
It's pretty good. It's definitely alcoholic. I can taste it, but there you go. Cheers, guys.
Cheers.
Cheers.
Well, Dr. Fichera, welcome again to the show. We are real excited to have you on because I joked recently that we have inadvertently become the J-pouch podcast because we have featured a lot of guests with J-pouches, but you are our very first colorectal surgeon to come on. So
what a privilege.
I mean, honestly, I'm really excited it's you because I think you're going to handle this really well because we definitely have questions for you and questions, I'm sure, from the audience as well. At some point when we get this episode out, we'll have some questions back. So we are very excited. But first of all, we want you to tell us, why did you get involved in inflammatory bowel disease? Why did you become a colorectal surgeon? And then why did you choose IBD?
Well, that's a great question that I get asked a lot, especially from my children when they were younger. They were wondering, why do you do what you do? It's disgusting, and there are so many other things you could be doing. Yes, there are so many other things you can be doing in medicine, but I think colorectal surgery is something that is associated with quick relief of issues. Whatever your problem is, we can improve it, not necessarily cure it 100% of the time, but improve it in a very short period of time. And the impact, at least for somebody like me that enjoys food and eating, with a major impact on quality of life, giving these patients the ability to enjoy food and drinks and life in general. It's a great privilege. So my father was a gastroenterologist, and I sort of grew up in his office. My mother was also a physician, so we were parked in different places during our childhood, and I spent a lot of time in his office, and I saw that the impact that he had on the life of his patients. When I grew up, I'm the only one. I have two brothers, but I'm the only one in medicine. Surgery was was an easy decision. After my anatomy class at the very beginning, it was easy. It was an easy decision. I wanted to do something that I had to do with my hands, and again can get a quick results. And colorectal surgery, it really depends on the mentors that you have along the way. So people that helped me along the way were colorectal surgeons, and I enjoyed their working with them and the approach they have. Colorectal surgeons are usually very easygoing. They don't feel like they're a gift of God to humanity. After all, we deal with poop, right? So it's if it is a gift, it's a gift that was regifted maybe. But an inflammatory bowel disease is because I had the privilege of training at Mount Sinai Hospital Hospital in New York, where Dr. Crohn practiced and described Crohn's disease. And you walk around in that hospital and you see old pictures and reprints of his original manuscript and references to the history of inflammatory bowel disease every day. And I spent 20 years at University of Chicago, which is another institution that has really written the history of gastroenterology and colorectal surgery in the US over the last decade. So I was sort of immersed in this IBD impregnated training programs, and here I am.
When you were training, because you went to medical school in Italy, so when you were training there, did you have any idea that this is what you wanted to do, or was it really once you got to Mount Sinai that this became kind of your path?
No, it was more when I came to the US. In medical school, you're sort of having a taste of a little bit of everything. Like it's like going to a buffet and you try the different type of foods, and you really don't know when you're done what you're going to do. And after you eat at a buffet, at least in my experience, you're so full that you don't even remember what you've eaten. So it's when I came to the US and I started training in general surgery is when I realized, what I liked and what I didn't like. And then, yes, when I went to Mount Sinai, it was clear that inflammatory bowel disease was going to be one specific interest of mine.
As I mentioned to you, we've definitely talked to a lot of folks with J pouches, and Robin being one of them. And we're definitely have said on the show multiple times that we feel like at times surgery being brought up as an option as part of somebody's treatment of their Crohn's disease or ulcerative colitis doesn't come up as early as it could. And you being integrated as part of a more holistic care team is something that you feel very strongly about. So can we talk a little bit about, in an ideal world that you could create for patient care, what is the role the surgeon should play? When should these things be discussed? What would you do ideally?
Yes. So the ideal world that you're asking me about is already reality in some institutions. There are several IBD centers, integrated IBD centers, where patients immediately seen by the gastroenterologist, the colorectal surgeon, the ostomy nurse if necessary, nutritionist, psychology or psychological support, ostomy support groups. So there are already realities like this, and it makes a big difference. I do see patients that come internally from our own gastroenterology, from our own IBD centers, and patients that come from the outside. And the first impact is completely different. Having a patient that has been informed, educated, is early in the course of the disease makes a big difference. When you come in late as a surgeon and patients see surgery as a failure, which is not a failure, but it's part of treatment, as you said, the relationship is a little bit more difficult at the beginning. So an ideal world is a patient that gets a new diagnosis of Crohn's disease or ulcerative colitis, and is seen by all these different people, not to scare them because they may never need surgery, but rather to have them understand the entire picture, the entire spectrum of treatment options. In fact, I remember a patient that I saw many years ago that was just diagnosed with ulcerative colitis, and he was presented with all the different options. Was a young man, he was traveling, he was a busy professional, and decided, it's the only one in many years, but decided that knowing what the surgical options are and where, he wanted to go to surgery right away rather than start a long, lifelong treatment that may or may not in the long run avoid surgery altogether. So he was healthy, was just diagnosed with ulcerative colitis. He was young, he was mentally prepared and ready for the pouch, and he did great. Now, this is obviously the exception, right? There are many steps to get somebody ready for surgery, but you need to have and know all the options for you to make an informed decision. And being sent to a surgeon that you never met when you are sick, malnourished, lost a lot of weight, lost your job often, cannot work, and hear about surgery is not the right time.
Again, talking about ideal time, you have somebody that you know is facing surgery that seems very likely they're going to need J-pouch or some sort of surgery. How do you work with your colleagues to get this person best prepared to have good surgical outcomes? What do you recommend? How do you work with that?
So that is another great question. It really depends on the timing, right? Somebody, for example, with ulcerative colitis, that is bleeding, that is anemic, that needs transfusion, you don't have a lot of time to optimize them, right? And on the other side of the spectrum, you have a patient with ulcerative colitis that is in remission and now has dysplasia and is sent to surgery. So those are the two extremes, right? I clearly remember a patient of mine in Texas that Jehovah's Witness, they came bleeding. And that, you don't really have many options, right? You don't have the option to transfuse. And obviously, I do respect 100% any religious personal belief. So we had almost an emergency situation that required expeditious surgery. So we had really no chance or no time to optimize. Otherwise, there are several medications, primarily steroids, that have a negative impact on surgical outcomes that, if possible, should be weaned or discontinued, if possible. And that is another important point that I want to make. I would rather do surgery on somebody that is in semi-remission on steroids than somebody that we discontinue the steroids. He has a full-blown flare, and now we need to do surgery while the patient is flaring. So it's a balance. Smoking cessation is extremely important in Crohn's more than ulcerative colitis, but in surgery, for surgery in general. And then nutrition, right? If a patient is mostly in Crohn's disease, has obstructive symptoms and cannot eat, total parenteral nutrition is an option. If you have time, it's something we would like to do. And lastly, also in Crohn's disease, if there is an infection, an abscess, or fistulas, or any other infectious complication, addressing that with either drainage or antibiotics or both is what we try to do. But this can only be done if we meet early. When you come in the picture at the end of the line, like again, these patients that was bleeding and couldn't be transfused, then there is really little you can. And that's the importance of having a close relationship with your IBD colleagues.
I know one of the things that I wanted to talk to you about is that, you've been in the game for a little while. You've seen the introduction to things like robotically assisted surgery, and that's something that you have trained in and that you're proficient in. But I'm curious if you can talk to us about the transition to that. What was that like to have these things introduced? And then how do you decide when it's the right time to use something like robotically assisted versus maybe a more traditional, way of doing surgery? Is that the right way to say that?
Yeah, no, it is the right way of saying. And I actually went through the transition from open surgery to laparoscopy, and from laparoscopy in part to robotics. So I went through these different phases. I was trained in general surgery, in open surgery, 100% open. And then when I went to Mount Sinai for my fellowship, I was fortunate enough to work with one of the pioneers in laparoscopic surgery. So there was that transition. So when I went back to University of Chicago, I brought those skills and expertise, and we trained the rest of the group. So everybody became proficient in minimally invasive surgery. And then over time, robotics started making a presence and being utilized in colorectal surgery as well. So we have transitioned into that field. The transition is really depends on how much effort you put into this new technology. When I was an open trainee, so not an open surgeon or an open trainees, there was a lot of resistance from the more established individuals that didn't think the laparoscopy was an option, especially in cancer. And again, there was a lot of resistance. And these people never adopted it. You have to stay open to new techniques and innovation, open but critical. For laparoscopy, we didn't see that too much, but for robotic, we saw a early adoption without data, without really a clinical trial to support it by a lot of individuals. And you need to stay critical and make sure you are embracing something that is safe, number one, and improves the outcome of your patient. So this could be a long discussion, and we do that in our division on a weekly basis. I think the robot adds quite a bit of benefits and advantages when working in the pelvis, especially. So for the last stage of the pouch construction, and in fact, tomorrow morning I have exactly that type of case. Granted, I can get to the hospital given the weather today, because especially in the narrow male pelvis, which is what I'm having tomorrow, the improved visualization of the robot and the fact that you control all the arms gives an advantage compared to laparoscopy. I know that there are still a lot of great surgeons that do the protectomy, the final part of the operation, through a small incision, like a C-section type incision. And they have great outcomes because the bottom line is you have to do what you are proficient in. So to ask an open surgeon to do a robotic operation once every blue moon, I don't think is the right approach. So stay open-minded and critical at the same time, and use the technology when indicated. The other issue I have in general in surgery is the one that are only one way, right? I'm doing everything open. I'm doing everything laparoscopic. I'm doing everything with the robot. There are, in my opinion, indications for all these different approaches. I do a lot of redo operations, and those are, in my opinion, they need to be done open. You need to explore the abdomen. You need to be very gentle with tissue manipulation. You work in different quadrants. So those are ideal patients for open surgery. The case I'm doing tomorrow is ideal for a robotic approach. And then in between, there is all this gamut of patients that benefit from a minimally invasive approach, and laparoscopy is perfect for those cases. So you need to be able to do everything, to be, good at all these different approaches. Obviously, you can have your preferences and your operation you like to do the most, but you need to have everything in your armamentarium.
Thank you for going into so much detail. My follow-up question to that, is that a conversation that you have with the patient?
Oh, absolutely. No, I do have the conversation with patients. In the Dallas market, it is very unusual to have a patient that comes that says, I want this operation done this way. It's very unusual, and that actually makes our life a lot easier. Other markets should remain nameless. People come with a operation, a day, a time, and whatever else already specified. And if you don't do it, they go somewhere else, which is great. This is not, it's a collaboration, right? It's I will explain to you why I think your idea is not perfect, it's not ideal. And the discussion I have, I offer options, and I tell the patient, I'm offering these options if there is more than one, because I think they are not necessarily equivalent, but all valid. Now, things that are not listed in this list of options is because they're either not valid, not appropriate, not safe. So that's how we discuss the surgical approach. Very recently, I had a colleague that called me and said, I have a patient with Crohn's disease and has an abscess, has a drain. He wants robotic surgery. So this is not the patient, so it's the doctor. So I replied, I said, if you want an open robotic surgery for this specific indication, I can give you a name of somebody else, but that's not, I don't think is indicated, right? This is a patient that if he has an abscess, he or she, I ended up never seeing the patient, it needs medical management. So before we discuss robot versus laparoscopy, whatever, we need to discuss, let's get this patient in the best possible condition to have the best surgery. So it needs a gastroenterologist. If you want somebody that will do robotic surgery, now I can give you a name of somebody else. And I haven't seen the patient, so I guess it's going somewhere else. But that brings up a great point of managing, especially Crohn's patients, in a multidisciplinary fashion. I mean, if somebody's flaring, sure, come and see the surgeon, but primarily needs a gastroenterologist. Perhaps with an abscess needs an interventional radiologist. Perhaps with a chronic abscess may need an infectious disease specialist. So it needs all these different specialties involved to get the patient in the best possible condition to have the right operation.
I have so many questions. I'm trying to pick one. I'm sitting here thinking.
Can I ask a quick follow-up? This is a very random question. When you're training to do something new, like learning to use a robot surgery, a tool, or a laparoscopic tool, how do you train for that? Because you can't just start shoving it in patients.
That's a great question. That is a great question. And I'm going to give you a answer that is not very popular, and that is stay away from industry. Because what is the goal of industry? To sell the equipment. So stay away from industry. If you know, personally, if I hear of a new procedure, new approach, and I know somebody I trust and respect that is doing it, I call them, I see if there is an option to go and watch them operate, or to get videos, or to invite them over if it's possible. It's becoming less and less of an option in this current climate, but I would rather be trained by a peer that I respect and trust rather than the industry. And then again, be critical. Don't start shoving things into human being without having done your due diligence and your appropriate training.
Thank you. That was a very concise and direct answer. I love it. I'm going to take you back. So one of the things that I like that you said is when you have the redos, for you personally, you prefer the open surgery because a lot of UC and Crohn's patients are, revisit surgery, have multiple surgeries. So I guess my question is, if one of our listeners is up for surgery and you are not their surgeon, they're not fortunate enough to have you, how would you recommend that they have that conversation with their surgeon? And I'm just going to speak from personal experience real quick. How the surgery was going to be done and options were not presented to me because I'm a redo person. So the idea of a surgeon giving, explaining the options that are available and like the ones that you think are necessary and would work, it's novel to me right now. My mind is blown.
Yeah, so I gave you a very generic answer. So there are redos and redos, right? If you are going through a pouch surgery, you can do it in two stages, 3 stages. I like 3 stages, but nothing wrong with 2. So those are planned redos, right? So those, I usually do the first operation, the colectomy, laparoscopic and assisted, because I think it's faster and saves time in the operating room and all of that. Then when the second stage, the removal of the rectum and creation of the pouch, I do that robotically. So that's also an example of use the technology that works best for that specific operation. Because I've seen colleagues do a robotic colectomy, 3 quadrants, it takes double the time. And I'm not sure there is a lot of benefit. So those are planned redos. So those are all okay, done minimally invasively. Now, when I'm talking about redo, when I was referring to are not the uncomplicated ileocystectomy for Crohn's that 10 years later has another obstruction. No, not those. I'm talking about the multifocal Crohn's disease that has had a resection or stricturoplasty, or a patient that has had a resection with a leak, reexploration, stoma takedown, another leak. Those are the one that I think, you can spend 8 hours in the operating room and take down all these adhesions and create another problem. Or you can just take your time and do an open operation and run the bowel, make sure you have, from not mouth to the anus, but from the stomach to the end of the colon, also because you give the gastroenterologist a roadmap that they would never get, right? You have seen, touched, and biopsied, if necessary, the entire GI tract. I've had 2 people that I trained in the past that were also drawing a map of the intestine with the length, which sometimes I do. I have it in the dictation for sure, but they would draw the small intestine and the operation they did and the disease left if there was anything. So incredible amount of information. So those are the redos I was talking about. I have a patient that I saw maybe a week ago that has had 4 or 5 operations, and they were all complicated by another leak afterwards or a fistula. And there is no reason to put this patient through a 12-hour operation with a risk of injuring other areas and not exploring the whole thing. So that is a patient that needs an open operation. So there is a spectrum in between, and sometimes you do a redo ileocystectomy in somebody you thought, this is going to be easy, let's try laparoscopically, and you have to convert. And other times when you expect a major problem, you start open and you think, maybe this could have been done laparoscopically, but those are the exceptions. You do know where you are in the spectrum of complexity.
When you're talking about any of this, like bodies are very complex things, and there's lots of other things going on down there other than just your colon and your small intestine. When you're doing surgery on somebody, how do you minimize the impact on other parts that are down there? And also just, I'm thinking about, you said somebody has almost like a C-section scar, like that's cutting through a ton of muscle. So how do you try to minimize any sort of damage that's going on by digging around in there?
Is there anything else other than the colon and the small intestine? No.
Uterus?
I
got one of those.
There was a joke for a colorectal surgeon. There is not much.
I laughed. I
Is that a colorectal surgeon joke?
Yeah. No, but so that is a great point. Now, one of the advantages of doing pouches, either robotic or laparoscopic, is the fact that you minimize the trauma, the damage to the reproductive organs, right? When we were doing this operation open, you have these big retractors moving the uterus and the ovaries out of the way. And the data is very clear that patients with the disease, with ulcerative colitis, their fertility is significantly impacted by the disease. But when they have surgery, open surgery in the old days, the disease gets better. So the quality of life improves, but their ability to conceive does not recover 100%. And that is the damage, we can call it damage to the pelvis that we were forced to cause when we were doing open surgery. So minimally invasive surgery in the pelvis can provide a significant benefit to everything. Now, also minimally invasive surgery, robotic or laparoscopically, the quality of the images now allows you to really identify the nerves that control urinary and sexual function. So that in male and female, postoperative urinary and sexual function is less impacted than used to when we did open surgery. I'm not saying we have eliminated those issues, not at all. The inflammation and the complexity of the operation and the redo operations. Patients may be left with some urinary, usually temporary, but some male have some long-term sequelae in terms of sexual function. So it's still an issue, but clearly better with the visualization that we get with the cameras.
I mean, when I think about J-pouch surgery, I go to recovery, right? Because like you said, either you have it in 3 or you have it in 2, or, it's robotic or it's laparoscopic. So I go straight to recovery because I think that a lot of our patients, that was the struggle between surgeries, the recovery between surgeries to get ready for the next surgery. So how do you optimize the recovery period to make sure that they are ready to go for the next phase and the next phase?
Yeah. So the first thing is, people have lives, so you need to set some sort of a timeline, right? Rather than, let's see what happens, because people have jobs and family and stuff like that. But you need to remain flexible, right? If you're just diagnosed toxic megacolon, you get your emergency colectomy, it's going to be easier for you to recover from that because you have not been on steroids for months or biologics for months. So it's going to be easier. Despite the very acute presentation, it may be easier to recover. Instead, you have been limping along, bleeding, and not thriving for months and months on different medication that gets escalated and hospital admission, this and that. It takes longer to recover. So my rule of thumb is I do 3 stages most of the times. I wait 3 months in between stages, but I see them back before I go to the next stage, because if they have not regained their weight, if they are not off the medication, then we wait longer. Now, there may be other issues to address, right? Smoking is one of them, and the weight. Sometimes people need to lose weight, and if you haven't, we wait longer. So it's a very fluid scenario. Now, the last step before the ileostomy closure, patients are usually in the best shape possible, so that those 3 months are usually a real 3 months. But between the first and the second, between the colectomy and the pouch, that's really where you want to see these people flourish and come back to life, like not just physically, but I ask them, what do you do for fun? And whatever it is, have you been doing it? No, not yet. Why not? Because I get tired or whatever. So the psychological aspect of it is also very important. So are you back to work? No, I'm not going back to work. Why? Because I don't like my job. That's a different story. But if you like it and you didn't go back because you're tired, you're afraid, you're whatever it is, then you're not ready for surgery. And it's not to prolong the suffering, but rather to optimize the outcomes after 3 surgeries. Because that's what I tell my patients. I mean, if you do a 2-step and you avoid the ileostomy after the second step, or you do 3 steps, especially for a 20-something-year-old, I tell them, when you're 80, you will not even remember that you had an ileostomy the second time. And what really matters, though, is that your pouch works for the next 60 years without any problem. So, yes, you can find people that do 2 stages for everybody, and more power to them. And there are others that do mostly 3 stages. But at the end, you want to have the right pouch that works great for you for the next 6 years or more.
You saying the right pouch working for 60 years just makes me feel so hopeful. I mean, I'm a little bit different situation because I have Crohn's in a pouch, but still just the idea of you saying that, it could work for 60 years. That just makes me happy.
Are you planning to live another 60 years?
I mean, I don't know. It's possible.
I'm not.
It's possible.
Well, we started doing pouches in the early 90s, right? So there are people that are out there that have had the pouch for 30 years, and they do exist. I mean, if you read the publication from the Cleveland Clinic, the Mayo Clinic, University of Chicago, and Sinai came out recently with a big series. There are patients out there that have had the pouch for 30 years. And the way
we've talked to them. They've been on the show.
Oh, great. That's great. That's great. And those pouches were done in a very different way. So I expect the newer pouches to last longer, right? It's not like cars, a 1960 Chevrolet will last 60 years. A 2020 Chevrolet will not last 60 years. But pouches are different. I think the way we operate on these patients now will allow them to last longer.
Okay, I'm going to ask one more, like an extension to the recovery question. And so this has come up because of the guests that we've had on our show who, through the process of having surgery and recovery, found out after the fact about a wonderful provider called a pelvic floor physical therapist. And this is just the discussion with us and other patients with J pouches. We are simply floored that having physical therapy after surgery is not automatically recommended. If you have knee surgery or shoulder surgery or any other kind of surgery, you are having some kind of physical therapy after that surgery, but it's not widely utilized after our surgery, which I would argue might be even more impactful on our quality of life. So I just want to get your thoughts on pelvic floor physical therapy. Do you work with one because you are a part of an integrative team, or I'm just curious?
No, you bring up a very good question. So in the very early years of pouch surgery, studies were coming out assessing defecatory function even before the pouch, and then comparing it to the function afterwards, and then following these patients, not necessarily long term, but following this patient afterwards. And the data was very interesting because there was a way, number one, to identify patients that may not be great candidates for a pouch, right? Because the other question is, do you do pouches in the elderly? Well, the elderly, that don't mean anything. It's not a term that means anything anymore, right? After this long case, I will feel elderly for sure. But there are patients, I have partners in my practice that are 70 plus, and they are not elderly for sure. So it's a number doesn't mean anything. So that is a way to objectively assess defecatory function before and perhaps select patients. Do we do it? Do we use it? No, we don't, unfortunately. And it's not just in pouch surgery. This is a big issue also for low rectal cancer and low anastomosis in general. Do we use them pre-op to identify this patient? No, we don't. We are still referring to the data that we got in the 90s. And that can also guide you in the recovery phase, right? We know how long it takes a hands-on pouch to recover versus a staple pouch to recover. Now, we refer to that kind of data still, but we do pouches, we construct the pouches in a completely different way. So that is a big lack of information and data and quality applied to surgery. Do we use, we work with the pelvic floor, especially we have a pelvic floor center that primarily though focuses on patients with incontinence and after vaginal deliveries and all those, which are very important issues, don't get me wrong. Now, if a pouch patient either has difficulty evacuating or incontinence, yes, we do refer them to physical therapy. But you make a good point and you ask a good question. Could we improve recovery, shorten recovery, perhaps even improve the outcome of these patients by recommending pelvic physical therapy for everybody? And I would dare to say the answer is yes. Finding a physical therapist that is interested in pelvic floor, not that easy.
That is true.
Finding insurance coverage for an indication that is, it's not soft. I mean, the indication to me is very clear, but again, it's not necessarily recognized, not that easy. So it is something that advocacy may bring it to the attention of the masses, both patients, of course, and physicians and insurance companies to provide coverage. We will still be dealing with the shortage of physical therapists that have an interest in pelvic floor because it is really a different animal. It's a different specialty. You need to be even more attached. I go to a physical therapist whenever I hurt myself, and I go to Alex. Alex is a nice guy, is a young man, and there is no way he would ever do pelvic physical therapy. And it's fantastic with what it does, but it's a different specialty. It's a different approach. But I agree with you. I think we could have a major impact on the outcome of low rectal cancer patients and pouch patients for sure.
Well, first, I'm pretty sure Robin would love to co-author that paper with you that we could come up with for this research project. But second, it also feels a little chicken or egg, right? Like it's like in order to prove that pelvic floor physical therapy needs to be covered more robustly by insurance, we have to prove that it's useful. But in order to make it useful to people, it has to be covered by insurance.
Yes.
So it's a little bit, that's frustrating because it feels very cyclical.
Yes. So the way a lot of these things have happened, an example is sacral nerve stimulation for fecal incontinence is the Europeans that have a different system can start a trial and get it approved and so on and so forth. Now, an approval proof of concept in Europe for physical therapy would be still hard to translate into the American system. But a lot of devices, so no physical therapy, have gone through trials in Europe where it's a lot easier to do the trials and to get them approved. And then they're brought here. Yeah, but it is the chicken and the egg for sure.
Since we started down this path, there are certainly some sexual implications for some choices that people would make surgically, especially for folks that may rely on anal sex as their primary source of sexuality. So I'm curious if you're comfortable talking to us about how you talk to patients about their sexuality and how it may be impacted by surgery.
Yes, this is part of the journey. So, and that is why early referral to a surgeon is very important, because somebody, if I think of that patient bleeding that I couldn't transfuse, that came with an hemoglobin of 7, there was no time to talk about sexual orientation. And also it's not an easy topic people want to talk to a perfect stranger they just met in the office. And that is the beauty of having a relationship with these patients over a period of time. But whenever we do surgery that involves the anus, either for cancer or for whatever reason, it has to be part of the discussion, right? I talk about postoperative sexual function in men and women, retrograde ejaculation and difficulty with erection, especially more for cancer than not. And then we sort of cover all the aspect of sexuality. In women, vaginal dryness, it's an issue sometimes. So you have to discuss it. Not that there is an alternative. I mean, if you decide to go for a permanent ileostomy, then there is no anal canal anymore. So it's the decision to not have a pouch is usually not driven by sexual preference or orientation. But as it is part of the potential changes in your quality of life, or afterwards, you have to. And it is part of my discussion before doing the second step. This young man that is going tomorrow, we had the discussion. As a young man, and obviously need to know all this possible sequelae after surgery. Again, not that there is an alternative. There is one option. We need to remove that rectum, but this is what you may expect afterwards.
Thank you for that. I'm really happy to hear that because we did have a guest on that his J-pouch surgery was a little more emergent. However, he was being treated the entire time leading up to said surgery where this could have been discussed with him. And he is a gay man, and he did bring up that it was never discussed with him, as it was part of his treatment. And that is disturbing to hear because you're right. This is part of somebody's quality of life. It's part of how they interact with the world. And so I'm glad to hear that you're having these conversations that I'm sure are uncomfortable for folks at times and for you at times, but are so, so important. So thank you for that. I appreciate that. Okay. This question, Robin, you're going to have to help me out here. So one of the things that has come up for our J-pouchers as we've been talking to them is that first stage, they get their ostomy. Some folks have resisted, don't love the ostomy, but pretty soon realize the quality of life is great. Love it. They can eat well. They can do a lot of things that they couldn't before. But then they do stage 2 where the type of ostomy changes, where you do the little loop. Knuckle.
The little loop.
The loop.
Yeah.
Why couldn't that was not going to come to me. The loop ileostomy. And a lot of folks really struggle with the loop part of the ileostomy aspect of things. As a surgeon, why is that? And are there ways to make that easier for patients?
So you bring up a very good question, and I will diverge a little bit. One other reason for doing the first step the way we do it is for patients to live with an ileostomy for a little while and see how it is. It is not uncommon, especially in older folks, that either they struggle to recover or after the first step, they come back to life and they're doing whatever they want. And then you start reading about pouchitis and pouch failures and potential complications and blah, blah, blah. and they don't decide not to have a pouch. I have had, at least in the last year, three patients, two women in a late 60s, I believe, and a man a lot older that after the first operation said, forget it. This is take this rectum out and be done with it. So that's another reason for doing the first step the way we do it. Then it's very important before you do the second step, if you're planning to do a loop ileostomy, to let them know that it's going to be a little tricky to manage it, because especially if they have been doing great with the end ileostomy that protrudes and it's easy to pouch and everything else, that is going to be a rude awakening afterwards. And again, there's no alternative, but just so they know, and you tell them that, yes, we will work with you, and it's going to be 3 months, and sometimes it's difficult, sometimes it's not, but it's not the same because the loop ileostomy is flat, and you have 2 lumens, and it's a little bit wider. So, you have to relearn it's less forgiving because, with the end, it's relatively easy to pouch, and there is intestine protruding there. If there is once it starts leaking or the wafer starts wearing off, you need to change it right away. So the maintenance is different, the whole story, and is a little bit more proximal, right? My patient for tomorrow, we met today virtually just to answer all the questions, and he brought it up. He's a paramedic, so he knows something about. He brought it up. He said the stomach is also going to be more proximal, so I may perhaps have a little bit more liquidy output. So it's less forgiving, more maintenance, and they need to know. What can we do to help? Well, it's a loop is a loop. It's not, there is not much you can do. Obviously, it's easier in thinner patients than heavy set, perhaps can protrude a little bit, not like an end, but a little bit more in a petite and skinny individual than the others. But there is really not much we can do other than prepare them and have a good ostomy support system in your hospital and outside.
I cried. I'm just going to put it out there. With that loop, I cried. It was hard.
Yeah.
It was so hard. So I'm glad that you prepare people, because I honestly wasn't prepared for how hard the loop was going to be. But again, in my case, to be fair, I hadn't had an end ileostomy for 20 years, right? So it's been a long time since I had an ostomy at all. And so, that loop. I'm so glad I don't have it anymore.
Yeah. 20 years is a long time. Yeah. Loops are not perfect. And that's the reason why a lot of people do what they call a modified 2-stage pouch when they do the colectomy first. And then they wait longer. They wait 6 months, not 3 like I do. And then at 6 months, they do the pouch without ileostomy in selected patients. That's the key, in selected patients. When I see people that do it, we only do modified 2 stages, then your leak rate must be skyrocketing. And it is. I did work with people that do only, not here in Texas, only modified 2 stages, and their leak rate was double what is reported. So the problem with a leak also is, we all get leaks. You only get leaks when you stop doing surgery, right? There is no way to guarantee that an anastomosis will heal no matter how good you are, how optimized the patient is. So leaks are part of the game. But again, you need to minimize the risk. I think patients that have had bad leaks, bad pelvic sepsis, bad pouch function, do not even remember having a loop. That loop, the 3 months of having a loop, they don't remember. Life is hard when you have a leak, pelvic sepsis, and a poor pouch function. So
yeah. That is true. I mean, I don't have poor pouch function right now, and I'm actually still really new. My J pouch is still a baby. So I'm going to switch gears on us a little bit, because I want to kind of lighten us up a little bit. On the questionnaire, we ask about fun facts, and I'm going to get this wrong, but do you quiz your residents or your fellows on the blues? Like what they know about musicians and history?
Yeah, no, I do. In the operating room, we listen to the blues. I think it's calm, it's relaxing. Some of my younger folks say it's sad. If the surgery doesn't go well and you listen to the blues, what are you going to do when you go home? I said, I listen to the blues on my way home and things get better. But yes, so I ask them questions, and usually I start with the students. They also, because my fellows have heard the same questions for forever, so they know the answers. But the students are so young that they have no idea. who B.B. King is, or Robert Johnson, or even Buddy Guy that is still alive. They have no idea. They look at me like I have two heads. So we have students from another medical school, and apparently at orientation, they are told that there is a surgeon that will quiz them on music. They don't say specifically what kind of music, but then they have put together a list of questions I ask, and they pass it on to each other. And I discovered this because one time I asked this young lady who just came in, first day on service. I asked her, I have a question for you. And she said, yes. She was ready for some anatomy question. I said, what's the name of B.B. King's guitar? And she goes, Lucille. I was like, whoa, wait. So either your father is a musician, or you own a record store, or you're cheating. So how do you know this? And being an honest person, she said, well, I was told about these questions and so on and so forth. But besides that, they don't memorize them all. So I usually ask them about the three kings of the blues. And there was this guy that remembers some. He says, B.B. King, and then he was thinking. I think he came up with the second one was correct, and then said, and the third one it goes Alessandro King, and I thought it was hilarious. I said, no, obviously not, but I mean you have a sense of humor. So go home, and when you go home, you look him up. And Freddie King was not Alessandro King, but and also the last fun fact is I had a fellow 2 years ago from abroad. I mean, he's U.S. educated, but he originally from abroad, and he listened to the blues for a year. At this last case, he comes up to me very respectful and said, Dr. Fichera, I need to tell you something. I hate the blues. You made me listen to this for 1 year. I cannot stand it. It is sad, and it's this and that and the other. And we were all laughing. I said, just say something. I said, no, in my culture, we don't complain, but I just wanted to tell you, I really hated it every time. I was like, well, I'm sorry, and now you know a lot about the blues, and maybe you should look into it a little bit, and maybe you'll appreciate it. But it was 1 year. They said it was torture. Every time I had to be with you, I knew what was coming, and
I mean, that's very dramatic.
Yeah.
Torture seems like
yeah,
a
he was a
dramatic
dramatic
thing to say.
person. I also have younger colleagues that whenever I go to help them, they ask me to come. I walk in the room and they tell the circulator, "Don't let Dr. Fichera bull you into playing the blues. We're going to listen to my music." So young folks don't like the blues anymore. It's sad. It's very sad. But,
I like
yeah,
the blues.
Alicia, we're not young, honey. We are not
Oh,
young.
that's
I like the
we're
blues
not
also,
anymore.
but we are very old. We're not the young people that Dr.
Again,
Fichera is
now
talking
who's
about.
being dramatic? We are not very old.
the
Robin.
20-year-old don't like the blues.
Well, there's no accounting for taste. I am curious. Are you into the blues because you yourself are a musician, or how did you start listening to the
I lived in
blues?
Chicago for 20 years. So somebody took me to a blues bar, and you walk in there. The place is so energetic, and it is not sad, as they said, but, you buy a Corona for a few bucks, you sit there and you listen to some amazing music. And the last few times I went there, I went back for meetings. Buddy Guy has a club where there's live music pretty much every night. And we went there one night, and he made a surprise appearance. And it's a small place. I was sitting on the second row, and the guy, one of the legends, the club is also called Legends, but one of the legends of the blues was right there, and was talking to us, and was just amazing. So it's living in Chicago, if you keep an open mind, like for robotic surgery and all of that, you get to appreciate and the history of the blues. I had a chairman when I was in Chicago that is a musician. He's actually a musician, and he actually performs. And hearing from him the history of Chicago blues, living on the South Side, all these different corners. So at the corner of this and that, of Clark and Cornell, there was a record store, or that's where Robert Johnson came to play once. It was amazing to get this full immersion into the history of the blues. So that's how I became addicted, as some people would tell you.
Well, Robin, you're planning a trip to Chicago. Maybe you got to add Legends to your itinerary.
This is very good. I should add Legends to my itinerary.
Dr. Fichera, it was so wonderful to talk to you and so good to get all these questions answered. Frankly, we may have to have you come back again because I'm sure we'll get lots more after we post your episode. But unfortunately, we are running out of time with you. So final question for you is, if you had one piece of advice for the IBD community, what would it be?
So I want to give an advice to the providers and an advice to the patients. And again, don't take this, providers, don't take this like I'm telling you what to do or I know better. But over the years, I've learned the principle of the 5 R's, and that you need to do the right surgery on the right patient at the right time by the right surgeon, supported by the right team. And that is critical. And I've written several papers on this, and it's very hard to describe the right patients because, especially in Crohn's, if you see 100 patients with Crohn's, you see 150 different presentations. So there is no guideline for that. But, the right patient is the patient that is not sick, is not infected, is not totally malnourished, is not on 40 of prednisone, and is not bleeding out. Oftentimes, you don't have an opportunity to optimize these patients. And the right surgeon is a surgeon that can do open surgery, laparoscopic surgery, robotic surgery, stricturoplasties, hands-on anastomosis, and so on and so forth. The right team is that, all the people that I mentioned before. The timing of surgery, the right time is the most difficult factor to consider, and the right operation. The right operation, please reach out to your colleagues. I get calls from former trainees, partners, or people in the community ask this question. There is no shame. When I have a difficult case, I call my mentors. I call people that I trust. We present it at their own conference, and I take input from the others, because oftentimes almost always, we don't have all the answers. So it's important to reach out if you have questions. And for the patients, same thing. Crohn's disease especially is now so complicated. When I was in training, we had 3 medications: steroids, and steroids. And there was nothing else. You can play with them, give a little more, a little less, but that's about it. Now there are so many different options. So like pelvic floor, physical therapy is a specialty. IBDology is a specialty. So while there are, surgeons and gastroenterologists that can do anything, you really need to look for a center, a group, or a surgeon gastroenterologist that specializes in that has a passion for that, and ask for second opinion. There is nothing wrong if you have, especially Crohn's disease. There is nothing wrong in reaching out and seeing other people for, if nothing else, for peace of mind. You have explored all the avenues, you've gotten all the answers you may need, and then you go and you make an informed decision. But an informed decision could only be based on facts that you have either heard from your doctors and or from others, colleague, friends, and the internet. I put the internet last because Dr. Google is not one of my favorite colleagues. Not colleagues. No one is one of my favorite.
That was lovely. I love that answer. We actually say that on the show often. Don't be scared to ask for a second opinion and look for a specialist. I'm so glad that you just made us sound smart. Thank you, Dr. Fichera. But it's time to wrap up. So we are going to say thank you so much for joining us. And thank you to everyone for listeing. And cheers.
Cheers. And if you had liked this, please come back and watch us again. I know you guys gave me a script on what to say at the end, and I don't work on scripts, so I apologize. But if you liked it, come for more.